Thank you, Ashok. Thank you, Neeraj Bijlani. I think you have all transformed the orthopedic education, and all of us so fortunate that sitting at home during this Ganesh festival and enjoying the festivities, also we can have a great initiative and a great academics. Thank you so much. And I'm thankful to Dr. Jitendra Maheshwari and Dr. Mukesh Laddha for accepting our invitation to spare their Sunday time and give us some important tips about managing two important aspects of knee joint or various joints. And Dr. Jiten Maheshwari would be talking first. He'll be taking the topic of knee stiffness. Friends, all of us keep on operating and all of us get patients who have a lot of knee stiffness during their post-operative phase. And their worry is not about walking. They're more worried now about getting the knee back to motion. And Indian perspective, getting a range of motion is more important to them. And Mukesh would be taking us through how to attach those small flimsy cartilage pieces where we find them intraoperatively during management of periarticular and intraarticular fractures. So both lectures would be very great. We are starting in time, 4 o'clock is the time now, and we'll be ending at 5 p.m. So friends, thank you very much for joining. And let us start with the first lecture. I would invite Dr. Jiten Maheshwari. Everyone knows Dr. Jiten Maheshwari. Once you listen to his lecture, we'll all be enlightened on this topic of knee stiffness. Most welcome, sir. We would all imbibe your wisdom. Sir, you are muted. Probably we are not able to. You will have to unmute yourself.
Okay, now can you hear
Yeah.
me and see?
Yes, we can hear you. We can see your first slide. Please go ahead.
Good. So thank you, Dr. Chandak, for taking this initiative. Now, this topic of post-operative stiffness is close to my heart because, my practice is mostly referral practice. I hardly get to treat fresh fractures, but I see all these referred cases, and if I close my eyes in last 25 years, post-operative stiffness after trauma surgery forms a very big chunk of my practice. And I can quickly say that the rate has gone down. If I used to see 10 cases of post-operative stiffness every month, say 15 years back, now that has become probably 3 or 4 cases, which goes to say that yes, the trauma surgery out there in the market in the periphery has become very good. That means surgeons are more and more aware about doing it well so that stiffness doesn't come. So let me take you through this approach. So to start with, this is my disclaimer that I am a little bit tubular vision of seeing neglected trauma. So for me, when I see a case of stiffness, I feel, oh, this trauma has not been done well, and the primary surgeon probably hasn't done it with care. But I know that is one of the maybe 20, 30, 40 cases, and rest of them may be doing very well. So when I see such post-operative stiff knees, and I start thinking, why did it become stiff in the first place? And then what should I do? I'm a secondary doctor. Patients have a lot of hope. They're already disappointed with treatment. So everything has to be done very, very carefully. So what is a stiff knee, first of all? And this is an important slide because most of us think that when somebody cannot bend the knee, that is stiffness. Actually, worse is what I call stiffness in passive extension. That means the person cannot extend his knee and has a 10-degree of flexion deformity. Now, that generally is unnoticed by the patient as well as the doctor as something okay. But that is a very serious thing, as I'll tell you in due course. Then we all understand loss of flexion, and by definition, up to 70 is considered stiff knee, but I think uh, 55, less than 55 is seriously disabling. So for most activities of daily living, you need about 70, 75 on knee flexion in normal Western population. But in India, a stiff knee, which means not bending at least up to 120-degree, is a severe disability. So in our country, losing knee flexion is a very, very major disaster. I mean, you can see everything done well, but I can't bend my knee. So that's not a very satisfactory situation for the patient. So two things. One, start identifying loss of passive extension And also knee flexion 70, 80 degrees, no good for Indian population. Now, what is stiffness in extension? That means you have a flexion deformity, which most patients actually somehow don't tend to complain. They're limping, but they're more worried about gaining more flexion. But whereas flexion deformity is a bigger enemy, why? Because it is more important. It is difficult to correct with time. You can gain knee flexion over a period of time, but if you do not gain knee extension completely very, very soon, say within 4 to 6 weeks of surgery, then that is very difficult to get after that. And it causes anterior knee pain because if you're walking on a bent knee, your range of motion may be perfect, but still you will have a anterior knee pain and you will have limp, which is a very important thing in lower limb. You will have a limited ability to walk. So even a 10 degree, 15 degree of flexion deformity with almost a full range of flexion can be a very disabling condition in long term. And a lot of patients come back rather late because they're limping, their pain, not knowing that it is coming from that slight flexion deformity that they are carrying with them. So it's
पूरा
very
सही
important to be
अलग
aware
बोल
of
दिया
flexion deformity.
मैंने अलग समझ लिया शायद
So that's one point I want to highlight. Be careful about flexion deformity. Now we come to loss of flexion, which we all understand. Patient will say, "Mera घुटना पूरा मुड़ नहीं रहा है." That's a very common complaint, but it corrects over time. If you are patient with time, with physiotherapy, it does correct quite a bit. It does not cause any limp. If you have no flexion deformity, you're walking around. It does not cause any limit in ability to walk. So those are good points. But bad points are in Indian society, particularly to get up from chair, to sit on the floor, to sit in the car, you need certain amount of knee flexion. And particularly when you have to sit on the floor, it is a big disability. So in India, loss of flexion is a big disability, but loss of extension is a common big long-term disability in all societies. So these two patterns of stiffness have to be recognized, and I'm more finical about getting the knee straight as soon as possible. But that causes limping, that causes pain, and that doesn't correct after some time. Very difficult to correct. Now, what are the reasons for knee stiffness after surgery? Now, we all do wonderful surgery. We expect a good result, but then at the end of 6 months or 4 months, you find the knee is not bending. So, what are the reasons? Sometimes the fracture itself is nasty. Multiple comminuted fracture. We know on day one, and we warn the patient that whatever I may do, I may be the best surgeon in the world, but you will have some stiffness left. So, this is a fracture inbuilt with the fracture that the knee will be stiff. But more important and very important is the surgery that we do. And very often, and I can say almost 70-80% of patients of knee stiffness that I do or I see are post surgery. And the reason is in the surgery itself. That means the surgeon probably did not understand some of the nuances of doing this knee surgery, that he thought he has done a great job, but then it has landed up with stiffness. And I'll come to those points. Post-op immobilization. This is a kind of, I would say, a reflex habit or bad habit to, to not mobilize the knee as soon as possible after surgery. And I've seen even patients being given plaster, possibly because the surgeon is not confident about a fixation and he wants to be secure and sure that the fixation should not, displace. So they immobilize the patient for some time, and that is a reason for stiffness after surgery. Then some patients do have a tendency for scarring everywhere, which is under nobody's control, everything very well done, but still the patient gets a scar and it becomes stiff. Another very important reason for stiffness is action not taken at the right time. And this is an example I will give. Patient, is not progressing very well, he's not gaining the range of motion, and you say, okay, continue physiotherapy, continue physiotherapy. And even physiotherapy says, okay, I will make it all right. You carry on with physiotherapy. That's not correct. There is a right time to intervene, which means for example, at 4 weeks, if your knee has a flexion deformity, you got to do something about it. Either get on with manipulating it with anesthesia, without anesthesia, give some kind of a push knee exercises, use a push knee splint to get on aggressively with correcting that deformity at the right time. Similarly, if you're not gaining knee range of motion, you have to start selling to the patient the concept of manipulation under anesthesia. Patients are very reluctant. So if I can see I have to manipulate at 6 weeks, 8 weeks, I start telling them from 4 weeks onwards. And when I tell them at 4 weeks, they are reluctant. But by the time, say 6, 8 weeks, they get ready to get manipulation done. So it's a little bit tricky with patient because they don't want any manipulation. Physiotherapist keeps ensuring them that they'll be all right. But at the end of it, sometimes things are too late and, the patient lands up with a stiff knee. Now, there are three fractures around the knee, we all know, distal femoral, proximal tibial, and patella, but they have different potential to cause stiffness. Now, all these three fractures are not same vis-a-vis stiff, capability or reason to cause stiffness. They're not the same. They're very different fractures, and I'll come to that. Now, let me talk about stiff knee after distal femoral fracture, which is the main. If I see 100 patients of stiff knee after surgery, I would say easily about 80% are because of distal femoral fractures. And rest are maybe upper tibial, maybe patella fracture, but a large chunk is distal femoral fractures. And I've got my little philosophy and understanding why these fractures get stiff so quickly and not the neighboring fracture, which is upper tibia, which does not get stiff so easily, but the distal femoral fracture gets stiff very easily. So look at this X-ray, very good X-ray, very well done fixation, whatever looks nice, but knee range of motion is limited. Another one, very nice X-ray. X-ray looks good, good alignment, but knee flexion limit. This is a very common thing. X-ray, bone has healed, everything is fine, but patient is not happy because the knee is not bending properly. Now, why does this happen? And I've tried to look at this. It is because of this important soft tissue in this area. I think this fracture is nasty because it has an important soft tissue in that area, which has a big potential in causing knee stiffness. And how does it cause it? It can cause it because of impalement. Very often, the fracture itself pokes into the soft tissue. And if you do not reduce it, absolutely hairline in the front, that bony piece that you can see keeps poking into the muscle and will cause impalement of the muscle, and this knee will be severely stiff. Similarly, at the time of injury itself, there may be injury to the quadriceps, which we orthopedic surgeons kind of overlook because we are looking at the fracture all the time. But this injury itself can cause a lot of scarring, and that can be a reason for stiffness because there's no flexibility of the muscle anymore. Third is sometimes the injury, the fracture causes injury to the undersurface of the muscle, and there is a lesion primarily because you have immobilized it. So because this soft tissue is there so close in the close vicinity of the fracture, so it is obviously a potential reason for causing stiffness. And there are three mechanisms that I've tried to figure out in my mind. And when I'm looking at them, I look at it, okay, which of the three is the reason, and then that decides my plan of surgery. So impalement, for example, this case was treated with minimally invasive and somebody immobilized, but this spike of fracture is actually in the soft tissue and will not allow. And this patient had only about 10 degree or 15 degree of knee flexion and had to be operated. And originally this fracture was like this, which means this piece of bone came out, cutting through the quadriceps, cutting through the skin, did not go back all the way. And it was still here and was causing impalement of the quadriceps. And this is what actually is happening inside this knee. So when you see this X-ray and you see a compound fracture particularly, and you see this anterior spike is not all the way back, this is not a good situation. Surgical or no surgical, that will give you stiffness. So this was a case again, I was called upon to treat, somebody treated conservatively. He probably thought alignment is very good, everything's fine, but the patient had a stiff knee because again, impalement of this spike into the soft tissue. So my message is that anterior surface of the femur should be nice and reduced and flat. So whether you're treating it conservatively or you're treating it operatively, this surface over which the quadriceps glides has to be smooth. And if it is not smooth, it will cause this adhesion of the quadriceps to this prominence. So a strict lateral view on the operation table when you're operating is very important because otherwise your quadriceps glide will not be good and you'll end up with a stiff knee despite a apparently, well reduced and well fixed joint. Now, next reason is inadequate fixation. Because if you're not sure about fixation, sometimes fractures are very bad. You delay mobilization because you're scared, and then that causes adhesion. And that is another reason for stiffness. Some of these examples, somebody treating this fracture with some two screws from not adequate fixation, and obviously surgeon will immobilize these fractures post-operatively and will end up with stiffness. External fixator, which used to be used quite a lot about a few years back, not so much now, is a potential stiffness generating machine in the thigh, because they put it like that and there's a transfixation pins, and these pins go through the muscle everywhere, and if you keep that more than X number of weeks, there is adhesion between the quadriceps and the soft tissue and the bone, and this knee becomes stiff because of transfixation of the muscle and leads to stiff knee. And so external fixator, this is an example, treated by external fixator, good alignment. So for some reason, end up with that kind of a stiffness, understandable, because there is no way this fracture will not lead to adhesion of the quadriceps everywhere. And in addition, the adhesion because of transfixation will add to stiffness. So you cannot use external fixator so lightly on the thigh on distal femur fracture. It may be required some time, but then you have to transfix it like this, leave that area for future because you may have to operate. So use external fixator only as a temporizing device for some time for your wound to take care, wound to heal. But as soon as possible, remove the fixator and convert this into internal fixation so that stiffness doesn't happen. So two things, don't apply external fixator as far as possible. If you have to apply, apply it for a short time and also apply in such a way that tomorrow when you have to operate, the operating area should be free of any pins so that you don't end up with infection. But I've seen over the years, this use of external fixator in the thigh has gone down significantly. It used to be quite a bit about 10, 15 years back, but now I know everybody knows that this is not the right thing to do in the thigh. So external fixator has to be applied carefully. Now, poor surgical technique is what is very important for us as surgeons, that when we are operating and we do something that we itself produce something on the table, which will give rise to stiff knee in due course, is what we should be very cautious. I think this is the most important part of this talk. Now, let me explain to you my philosophy on this. So knee joint has three gliding surfaces. We all know two gliding surfaces, which is between femur and tibia and between patella and this. If there is any loss of movement in these two surfaces, there will be stiffness. But there is a third gliding surface which we tend to overlook, and which is what I call reticular joint. The gliding surface between retinaculae and femoral condyle. That means this surface. So there is one joint, there is second joint, and there is actually a third joint. If this movement between the femur and the retinaculae is not smooth for whatever reason, this will produce stiffness. If the gliding between these two surfaces is not okay, it will produce stiffness. This too we understand very well, all of us. But this is something not very well understood. And very often AP lateral looks normal, but the knee stiff. Why? Because this gliding surface is not being taken care. And I'll give you some examples of this. So look at this. Now, looks very good. Lateral was very good, but knee was stiff. Why? Because this screw was too long. And we understand that femur is a trapezoidal bone. And if your screw length is equal to the overall width of the femoral condyle, it is a long screw. That means that screw is poking medially. So all the screws have to be shorter than the overall length. So when you're doing surgery, you take a AP view, this screw should never be crossing the full width of the femoral condyle. Otherwise, you'll end up with a prominent screw, particularly if they're anterior screws. So all these distal femoral plates, anterior screw should always be shorter than the full length of the AP view that you see under image intensifier. Otherwise, you are putting long screws, you will not be able to find it on the table, and they will not allow flexion of the knee because the motion between retinaculae and the distal femur is restricted. This movement is restricted, and you'll end up with a stiff knee. Similarly, bulky implants and all these distal femoral plates are very bulky for Indian patients. And unless you put them exactly where they belong, they are very big space occupying lesions there, and they do not allow the retinaculate to glide again. So this is a very common reason for a stiffness, the use of these plates. And to actually put this plate in the right place in every patient is a big learning curve. So I see all the time these plates are a little bit too anterior, they're too prominent, and they are biting on the retinoculate, they're biting on the iliotibial band. And because of that biting effect, the knee becomes stiff. And I do these surgeries. I know I have to open up, release the knee, and then remove the plate. And if I don't remove the plate, just do a release of the knee, this will not work because the cause of stiffness is here. The prominence of the plate, which is causing retinaculum femur gliding problem. So this is an aspect which one has to understand. So how to prevent stiffness after distal femoral fractures? So my message is anatomical reduction of anterior femoral surface. So good standard a lateral view on the table and make sure that your anterior surface, there's no spike poking. Because any spike is there will not allow gliding of the quadriceps and adhesion will happen. Adequate fixation because you have to early mobilize this fracture. I'm not a very big fan of AO philosophy of early mobilization everywhere in the body, but one region where I'm very, very fastidious about mobilizing them early is distal femur. I have to use one plate, two plate, five plates, I don't care. But on the table, I must have a good reduction and I do not even immobilize even for a day, whatever fixation I may use, because stiffness of the knee is a big enemy if you immobilize them. No implant impingement. So you have to use your plate carefully. They are very bulky. Let them be a little bit on the back, posterior side of the femoral condyle. Make sure they are hugging the plate very well, hugging the bone very well. You may have to, mold it a little bit patient to patient. And then early mobilization. So these are the reasons how you can prevent stiffness after you have fixed a distal femoral fracture. Now, very simple to say, if you are fixing a distal femoral fracture, fix it well. Simply said, but difficult to do. So I'll give you some tips that I have learned over the years. Good exposure is very important. It's a very, and so many approaches are there. And we do go by the subvastus approach, the minimally invasive. Sometimes it is easy to operate. If it is a supracondylar fracture, you can do it very well. Sometimes it is a bad intercondylar fracture. And to actually move the patella on the other side and still be able to do it is technically quite difficult sometimes. I personally do not hesitate, and I do a lot of tibial tuberosity osteotomies generally for other reasons, in patellar surgery, in TKR sometimes. So I think it's not a bad idea to just do a longish patellar tibial tuberosity osteotomy and shift the whole thing. The way we do it in, distal humerus fracture. We do osteotomy of the olecranon and everything becomes a cakewalk. So sometimes when you're struggling to fix a complicated fracture in this area, I have found it very handy to just simply do an osteotomy, chip the whole thing otherwise, and it is not a difficult job to fix it and it does not interfere with mobilization. Very simple to fix it with two or three screws like this and it doesn't hinder. So sometimes when you're struck with a situation where you're not able to see everything properly, I think it is a suggestion that you can go on with this. Initially, there's inhibition. I know a lot of trauma surgeons, my colleagues have inhibition about doing this, but Mukesh knows and we do it all the time. So we just do it whenever required. So accurate reduction is important, for which rebuilding of condyles everybody knows, but keeping the trochlear shape is very, very important. So sometimes we put all kind of compression screws here without realizing that you are actually stenosing the trochlea, which means the trochlea and the patella are not in proper congruence, and that will lead to incongruent movement at the patellofemoral joint and cause stiffness. So you have to look at that middle part of the trochlea and you have to reconstruct the trochlea properly. It's a bit of a tricky thing. Small screws are required, maybe bone graft is required. So that is something, sometimes those bad fractures of distal femur need this attention. But otherwise, everybody knows coronal alignment, sagittal alignment, rotational alignment, everybody knows all that. But this is something sometimes missed because you put a compression screw and then everything is squeezed and the trochlea becomes very small and the patella doesn't glide. Now, sometimes you have to use bone grafts because these are very badly comminuted fractures to reconstruct the distal femur, particularly the trochlear area, particularly the condyles. You may have to use a bone graft or bone cement or some kind of a thing to actually get the shape of a normal femoral condyle for proper gliding of the patella and the quadriceps. Now, you do have to immobilize post-operatively sometimes. I wouldn't say I'm always 100% clear there. Sometimes I have my own hesitation that if I mobilize, the bones are osteoporotic, everything might just fall apart. But even if you immobilize them, it cannot be 24/7 immobilization and forget about it. Like putting a plaster for 3 weeks, that's not a good idea. Even if you're immobilizing, immobilize in a brace and at least find a sensible range of motion on the table before you close, which you will allow the patient to move even 20-30 degrees. So it cannot be zero movement. It has to be at least 120-30 degree where you will not lose the range of motion, but you will prevent adhesions of the quadriceps on the femur. So no plaster application. It has to be a brace and intermittent mobilization within the brace after removing the brace. Maybe 10 degree, 20 degree is useful rather than putting them in a plaster. Now, when you're mobilizing them, that's also a little bit tricky in distal femoral fractures. Now, I say if you're not confident about your fixation, it is better to turn the patient around, stabilize the distal femur, and bend the knee. Then you're not transmitting forces here. If you're scared, because if you do otherwise, which means you tend them to ask them to bend the knee like this, all the force is here, and if your fixation is not good, you may actually lose fixation. So if you're not secure about fixation, it's a good idea to turn them upside down like this and still bend the knee. Bending of the knee is very important. Otherwise, distal femur fracture is waiting for stiffness. Now, there are some fractures I used to get. Now I don't get them so often. And I understand that probably AF philosophy has gone quite deep into the mind of a lot of my colleagues. And now they're doing a better job. But this was a very favorite fracture of knee, stiff knee with a uricondylar fracture. This was a big time practice that there was a small fracture, somebody fixed it, thinking it is a very simple fracture, immobilized it, and that lands up in a stiff knee. And I had a big series of these cases, and all kind of fixation used to come, percutaneously done, no plate, just wires, just screws, and then immobilize. And as soon as you immobilize a operated knee where distal femur has been operated, you will end up with a stiffness. And I have n number of cases which have been fixed by every method possible and end up with a stiffness. Small fracture, simple fracture, but not understanding that if you have to fix these fractures, you have to fix them well, that you can mobilize them next morning. If you don't, they'll end up with stiffness. And as you know, all these cases belong to that series. So whenever you have a fracture of a unicondylar, which looks a very novice kind of a simple fracture, you have a tendency to do percutaneous, maybe or even open one or two screws. That is not adequate fixation, and you will delay mobilization, which means you'll end up with stiffness. So some kind of a buttressing is a good idea. If you buttress like this, you can mobilize them next morning without worrying about displacement, and you will not have a stiff knee. Now, stiffness after tibial fractures. A couple of thoughts. I don't see too many fractures of tibia landing up with stiffness. It's very interesting. The problem of distal femoral fracture is actually stiffness. But problem of proximal tibia fracture is not stiffness. It is varus deformity. It is malunion. It is limping because of malunion. They don't get stiff very often. Even if the worst of varus deformity, you find the range of movement is very good. Why? Because that, the soft tissue like quadriceps is far away from distal tibia, proximal tibia fracture. That's why. So I don't see many fractures of proximal tibia landing up with stiffness. They'll end up with malunion. Again, stiffness in extension. That means there's a flexion deformity, and mostly it is because of some door stopper effect from one of the fracture fragment from the tibia. Usually maybe ACL avulsion. Sometimes there's a fracture fragment which is not allowing the knee to go straight. Similarly, there can be a door stopper effect from the fracture part at the back of the knee, which is not allowing the knee to go into flexion. Now, if you don't recognize these two things on the table, you are leaving that knee to get stiff either in like flexion or maybe extension and all these movements. So when you're doing a AP lateral view, or particularly a good lateral view on the table, There should not be any piece poking in the joint, either in the front or at the back. If you have that, I'm sorry, if you leave it as it is, it will end up with stiffness. Patellar fracture, I see, and again, I used to see quite a few patellar fractures treated and landing up with stiffness, not so many now. And I think big time stiffness used to be when we used to do patelectomy. So 20 years back, patelectomy was quite a popular operation, not so much popular now. And I used to do a lot of patelectomy done, which they immobilize for 6 weeks and they'll end up with stiffness. And that used to be a big chunk, but that had disappeared. So I was myself thinking that a lot of my practice has changed. That means the surgery out there in the community and the periphery has changed also. So probably people are treating the fracture patella very well now, and they are probably mobilizing them quite fast. So one reason is irregular reduction, the gliding surface, and that leading to no smooth gliding. Again, when there is no smooth gliding in a gliding surface, there is stiffness scope. Then another one is you're not sure about fixation and you immobilize them. Again, immobilize them in a plaster is a disaster. Even if you have to immobilize and you're not sure about fixation, maybe a brace is all right. Now, lack of action at the right time, if they're not getting good movement, I think at some stage I have to start asking myself, is it time to manipulate them under anesthesia? Don't delay them so much, they're 6 months, then after which I would not like to try manipulation because I will end up with a more complication of creating a fracture. So what happens is if you don't manipulate at the right time, take an action at the right time, then it becomes a bigger surgery. Either manipulation with risk, or I have to do arthroscopic surgery or even open surgery sometimes. So this lack of action is a very important reason for a residual fixation, residual stiffness after knee surgery. Let me have these two slides, the last two ones maybe. How not to let your knee become stiff. Very simple. Distal femur fracture, fix well, fix well, fix well. Mobilize them early. Use one plate, two plate, three plate. But on the table, you should be able to bend 90-degree comfortably. And you can tell your physiotherapist, okay, you can move that much. And don't immobilize them at all, more or less. Proximal tibial fracture may tolerate immobilization better. You will not end up with so much stiffness. So it's a secure situation. Patellar fracture, again, you have to mobilize fairly early, otherwise they'll end up with stiffening. Now check on the table stability for safe zone. So if I know I cannot give this free hand to my physiotherapist, I will tell them, okay, I have tried to bend it to 60-40 degree and it is quite safe to bend that much. Don't bend more because I'm not secure about my fixation. I'm not secure about bone quality. But I will still tell them bend 0 to 40, no problem, because I don't want a stiff knee there. In the form of treatment principles, I would say assess the knee and look for bony reasons. Whether it is stiffness in extension, which is missed very often, most of us concentrate on flexion stiffness. Look for bony reasons. In a good lateral view, malunion or door stopper effect in the front, in the back. Sometimes difficult, and you have to do even a CT scan to find out whether there is a door stopper effect. Because these cases, even if you release them arthroscopically or open, if there is a bony defect there which is causing door stopper effect, you will not get a good result. So, of course, if there is no bone stopper effect, soft tissue is the main reason for stiffness. And when it is a soft tissue, it can be anterior scar adhered to the femur. So whenever there is a incision made on the front of the femur, which is the common approach in every surgery, even TKR or anything, the stiffness is right there under the scar. Very good cases for surgery. For arthroscopic release are the cases where there is a scar in the front of the knee. Because I know I go with the scope, the adhesions are going to be right there and there will be no adhesions medially, laterally, and I can just release and the knee will bend very well. So presence of a scar is a very good sign that this is a good case for arthroscopic release particularly. Now retinocular adhesions and thickening. So I've gone away from arthroscopic release in severe knee flexion losses. I used to be very fanatic about doing it arthroscopically a few years back, but I realized it is difficult. You don't do a good job and the recurrence is high. Whereas if you do an open one and actually excise the lesions nicely and take away half of the retinoculum is actually 3 times the size of a normal retinoculum. It is so thick, you cannot remove it by any kind of a shaver. So you have to open up, remove almost 2/3 of the retinoculum, remove all the tissue from back of the patellar tendon, which is almost double the size of patellar tendon. So those things are not possible by arthroscopy. So I have over the period gone away from arthroscopic release, particularly the stiffness is nasty. So 0 to 30-degree movement, 0 to 40-degree movement. I prefer a open approach because I can do it much better. Retropatellar fibrosis is a thick, the patella is almost 4 times patellar tendon. And you have to release that, you have to remove that, relieve just the patellar tendon and no tissue behind the patellar tendon, and then only the knee moves. Extra-articular adhesions in a supracannular fracture, they're adhered there and you can release with the osteotome all the way up. And sometime when you've done all that and knee is not bending and you've done everything, all intra-articular release, you look at the quadriceps. Sometimes the quadriceps scale is scarred. For example, vastus intermedius, it is injured in the supracondylar fractures and it is not visible in any way. Once you have done that, you feel the quadriceps and you feel it is quite scarred. Then you have to remove that scarred portion of the quadriceps. I have gone away from doing Z-plasty. I have not done a Z-plasty for last 20 years for quadriceps. I just remove the sclerotic quadriceps, which may be a part of the intermedius. I take the rectus away. I remove the scarred intermedius and just the movement comes. Or I may do pie crusting of 1 or 2 muscles, whichever is scarred, and then the scarring effect of quadriceps is gone. So like I don't think there is a need for a formal quadriceps plasty nowadays, except in cases where they are, for example, drug addicts and they have a diffuse scarring because of multiple surgeries. Maybe quadriceps plasty may be required. Otherwise, it's a limited quadriceps surgery. Just remove the scarred part of the quadriceps, do Z-plasty of the rest of it, or maybe a pie crusting of rest of it, and you will get a movement there. So if I talk about step-by-step release in a patient with stiff knee, I go to suprapatellar pouch first. I go to the gutters. Then I go retropatellar, remove all the big fat scar tissue from back of the patella. Then I go extra-articular if it is a supracondylar fracture. And then finally, I remove the scar from the quadriceps. I've done all this, the knee should bend. I only dare to try bend the knee after I've done all this because I know if I try prematurely, I can cause fracture supracondylar or I can cause avulsion of the tibial tuberosity. So that's a very important step when you are very sure that there's nothing holding this fracture anywhere. There's no bony door stopper effect, and then only you with the in the name of God, maybe Ganesha these days, you just give a gradual bend, and hopefully you will not cause any fracture. So hardly any quadriceplasty and manipulation with care after you've done all these steps. So to conclude, if you want to prevent stiffness, it is the distal femoral fracture which is the main enemy. Look at the importance of tissue right on day one from the pattern of injury. If it is a compound fracture or it is a bad quadriceps injury, quadriceps is going to be an enemy. You have to mobilize it as soon as possible. You have to achieve good reduction intra-articular as well as extra-articular, for which good exposure, proper alignment is important, stable fixation is important, fixed good and good enough that you can mobilize it next morning. You can use 1 plate, 2 plate, as I told you, even 3 plates sometimes, but you cannot afford to immobilize a distal femoral fracture and use fixator with care. And that is about and unicondylar fracture, as I showed you, are another set of simple looking fractures, but again, they are stiffness creating machine, I call them. And as far as treatment is concerned, look for bony reasons. If you have bony reason for stiffness and you start doing soft tissue release, arthroscopic release, and then you try to bend, you will actually create a fracture because that door stopper effect of the bone will not allow you to bend. So you have to be very careful. In the lateral view, there should be nothing in the front, nothing in the back, which is a bony thing, which will not let your knee bend. And we have a tendency to, that manipulate, and you'll end up with more complications. If there's no bony reason, then sequential release, as I've shown, you go from suprapatellar pose downwards, and then in the name of God, do a gentle manipulation. Now, maintaining this range of motion that you've gained is another tricky thing. And I always keep them for 2 days in the hospital for a epidural analgesia and bend them. I sometimes send them home with epidural analgesia. And post-operatively, they get painful, they don't move it, and they go back to zero. And I tell them, I'm going to manipulate you again after 2 weeks if you don't go beyond 90. And I admit them again, manipulate. So my remanipulation rate is very high because once you gain that movement and patient is not able to keep that movement because of pain, it is a recurrence. It is a loss of, you lost everything. So need for early remanipulation is emphasized on the day of surgery. That if you don't bend it, I'm going to take you again to the OT and manipulate rather early and not wait. Once you wait, adhesion forms again, then it becomes a repeat surgery more or less. So with that, I think that's my last slide, and I'm sorry there was no interaction. I didn't prepare it that way, but it was a monologue more or less. But I'm ready for questions.
Thank you very much, sir. That was wonderful. You brought out really very nice points and nice concept. And the joint of retinacle with the femoral condyle, where it stiffens quite often. That was wonderful to see. And that was a masterly lecture. Any questions to Dr. Jiten? Mukesh, your opinion?
Sir, excellent lecture, no doubt. And one thing, after post-trauma, knee stiffness, arthroscopic release is extremely difficult. I think what open release, releasing all the gutters, fat, scar tissue, that gives more better result than our arthroscopic release. Sir, what's your opinion, Jiten sir?
Yeah, exactly. So,
Hmm.
about 25 years back, all these patients used to be sent to me because arthroscopy करा लो वहाँ पर वो जल्दी से मोड़ देंगे. And patient was very happy to understand that this can be a small surgery and my knee can bend. And I remember in my early career, I've done that. And I used to spend, 1.5, 2 hours getting everything, but all those shavers don't remove. And then you have temptation to get it. But I never used to get the kind of movement that I wanted to get on the table. And I was always scared that if I just push it a little harder, I will end up with a fracture. And so then I changed my plan that I let me do a few open. And when I opened up and excised all the scar tissue in front of me with my own eyes and open surgery, I have never gone back to arthroscopy because I know no arthroscopy can release that kind of adhesions. They are thick adhesions. Like whenever I do a repeat, for example, two-stage revision of infected TKR. So when I open up the reticulum is so thick. So part of the surgery is actually making the retinoculum exactly what it was on day one. It's so thick you have to
Agree.
almost two-thirds of the retinoculum thickness and almost two-thirds of the patellar thickness, patellar tendon thickness. So that's not possible by arthroscopy. These shavers are not that sharp.
Anyone else would like to ask any question? Please go ahead.
Maybe somebody can share their experience if they have treated a
Yeah.
stiff knee. What was
So
the difference found?
in case of postoperative knee stiffness, if you're not doing by arthroscopy, how do you release patellofemoral articular adhesions? So
Yeah,
which
for that, need to completely take a TKR incision, remove the retropatellar fat pad,
okay,
and clearing the gutter will release much of the things. And I think elevating the quadriceps from the anterior femur, provided they are not scarred, then that gives excellent flexion. And that excision of the retropatellar fat is much better in the distal half of the patella.
okay, perfect.
So trick
Absolutely.
here is cleaning the gutters. So when you
Yeah,
open up from the lateral side, for example, or midline, sometimes you're not able to reach the gutters all the way back. And you have to go all the way back. Like my almost whole finger should go inside the gutter, then only the release is done. Otherwise, sometimes when you're bending them after the surgery, you can hear some crackling sound, which means that there are some adhesions in the gutter which I'm not able to release at the time of surgery and they gradually go. But when the crackling sound is happening, my heart rate goes up because I don't know what is cracking inside. So over the years, I have got the experience that this is soft tissue crackling and not, you know, the bone cracking. But that's a fear all the time.
Doc-
so Dr. Mantri has raised his hand. He would like to add something.
Yeah, Dr. Manti sir.
Yeah, Dr. Jeetendra, just my question, leaving aside your all other points which you have informed, quadricep trauma seems to be a important reason for the stiffness. That's why you find the difference. Tibial fracture is more forgiving in a stiffness, and the femoral condyle fractures or distal femur fracture is in a more producing the stiffness. What is your opinion?
So this is my observation in the sense, if I see 10 patients walking to my clinic with a problem of post-operative stiff knee or post-trauma of the knee stiffness, it is 8 out of 10 are distal femur. So I wonder why there is no stiffness after tibia, after tibial fractures. Because somehow they start bending and they bend, they're deformed. Everything. You will see a very bad looking distal proximal tibial fracture, very bad looking, but good range of motion.
Good range of movement. Yeah.
The stiffness is not a problem with proximal. And I read somewhere that you can immobilize the proximal tibial fracture even for 6 to 8 weeks and it will not give rise to stiffness. But you cannot immobilize distal femoral fracture.
True.
Thank you very much, Dr. Jiten sir. Mukesh, can you share your screen and you can start?
Yes,
your,
I'll go ahead with my screens. Is it visible?
Yes,
Yeah.
it would be interesting to how to fix those small osteochondral fractures.
So thanks a lot, Dr. Chandak sir, for this great initiative as usual, and excellent talk by Dr. Maheshwari sir. So what I'll share is not only how to fix it, but also how to repair it or how to reconstruct them. So these osteochondral fractures most commonly are seen in patella following primary traumatic patella dislocation rather than distal femur or osteochondral fractures of the distal femur. So young girl, adolescent female suddenly came with pain and swelling. Always a common history, sir, kuch to hila aur andar aa gaya. And then they have swelling, and you can see those small tiny pieces in the knee that should raise your suspicion. And of course, all CT and MRI should be done early in such cases, though you may see a lot of hematoma and other things. But in adolescent, a big osteochondral lesion like this may be very detrimental in the future. Hence, whenever an adolescent comes to me with swelling in the knee, sudden onset, while running, they say, sir, I didn't have a fall, but kuch to laga and I just fell. And there is effusion not subsiding within 4-5 days, I'll go ahead. So this osteochondral fracture I fix with, you can have various modalities like small K wires or Hubbard screw, but then they are all metal inside. So my preference of fixing such fractures is using a biopin, that is biodegradable K wires, which comes from Arthrex company. They come as a set which has a drill bit and a drill sleeve. So you reduce the fracture first with, and then try make the trajectory with the help of the drill wire, which is provided, and gently tap it. The only thing which you should do is definitely, like you fix all other fractures, you should have a clear anatomical reduction, because intra-articular fractures, even a small amount of malreduction, it won't tolerate. And then you need to flushly cut it so that even a 1 millimeter proud of this biowires will irritate the trochlear cartilage. Fix it and the patient will, you can mobilize them very soon and they will never go into stiffness of post-op pain. Sometimes you have young girl who had a acute swelling, but x-rays are inconclusive. Then also do an MRI and see that on the medial tibial patella facet, you can see some chondral damage, and in the center image above, you see a small flake of some cartilage lying in the intercondylar notch. So this was the young female having almost half of the lateral medial tibial plateau chondral fracture, only chondral fracture, but she reported to me very soon within a week. So you can fix those chondral fractures as they are within the week. Beyond 3 weeks, this chondral fracture gets swollen up and the viability of the cartilage goes down. So fixing plain chondral fractures beyond 3 weeks is really extremely difficult with no results. So if they come, you should need to have a high degree of suspicion. Get the MRI soon. Nothing will hamper because you can pick up those chondral lesions very well. Fix it. X-ray won't show anything post-operatively. Patient have no instability, nothing. Most importantly, the post-op MRI shows that the cartilage is completely healed up to the parent bone, and the medial patellofemoral ligament also has regenerated or recreated himself. As you can see, I don't do any primary MPFL reconstruction in this traumatic patella dislocations with osteochondral injury. So chondral lesions coming soon can be fixed. Another young chap with osteochondral fracture, skyline view, you can see the defect in the patella. and a big lesion with all altered TTTG and other things. But he is a 27-year-old boy who have lived with all these bony abnormalities, and it was a traumatic patella dislocation with this huge osteochondral fracture. Again, what I did after clearing the fracture site, fix it with biopin. No need to reconstruct MPFL because it's a traumatic. If they come with a traumatic lesion with this fracture, I'll go ahead and do all that bony procedure in one stage, but not in traumatic lesions. And that's after fixation. And that's 1 year, even after surgery, having that abnormal TTTG, there is no instability to the patient and he's having full range of movement and doing all his activities. Sometimes being patient coming from very rural area, you have these neglected fractures where I've seen only one fracture like this, like a non-union of medial facet of the patella in a 17-year-old boy. I thought initially it was a loose body, so I told them that I'll just remove it. But after observing it carefully and after seeing MRI, I can see the whole of the medial facet of the patella was into non-union. So removing that whole non-union and getting something else. So I thought I'll just debride it and prepare and treat it like a non-union after completely removing those scar tissue between the non-union site and fixing them with multiple biopins in different directions. One thing about biopin is that it should not be proud even on the anterior surface of the patella, otherwise they will cause retropatellar or prepatellar bursitis, and it should not even be proud on the articular side, otherwise it will damage the trochlear cartilage. So you can fix them, and even such bad osteochondral non-union fixed with biopins, you can see there is complete union of the fracture fragments within 6 to 8 weeks with full movements of the patient. Bicortical biopin fixation is must, no proudness, no need for any implant removal in the future. And in acute traumatic, there is no need to do either any stabilization procedures like MPFL reconstruction, though world differ on it. Many of the people say you need to do, but I have my own series which I have published, and I feel there is no need in traumatic injuries. Now, sometimes though patient comes to with you with the trauma, but you see this is a 20-year-old physiotherapy student with a huge subchondral bone marrow edema and osteochondral lesion. Mainly it's osteochondritis dissecans. The reason here is some vascular insult to the subchondral bone because cartilage gets its nourishment from the subchondral bone. And this patient, it's usually acute on chronic. They do have some kind of discomfort, but a trivial trauma will bring them to you, and you see such kind of bad subchondral marrow edema with subchondral cyst and a huge defect in the subchondral bone in a 20-year-old physiotherapy student. You can see it's almost a 16 central bone defect with cartilage loss on the medial femoral condyle. I went ahead and did bone grafting in first stage so that I can fill that big defect, because no cartilage repair procedures or anything will work with that bad subchondral bone. So for healthy cartilage, you need to have a good subchondral bone, hence bone grafted it arthroscopically, taking the cylindrical graft from the distal femur itself, waited for 4 months. And after 4 months, you can see the bone graft has healed up very well and did second stage ACI, autologous chondrocyte implantation in this patient, where I took the biopsy in first stage, send it for cell culture. And this is a reruxcopy after 18 months in the same patient. You can see that there is some fluffiness in the cartilage, but it has healed up very well. And the relook and the MRI 18 months still show some marrow edema, but you can see the uniformity in the cartilage and the swollen cartilage, which is very well seen on the MRI. But post-op MRI doesn't become normal at 18 months. So the same patient, 5-year post-op MRI, you can see there is the significant reduction in the marrow edema. The graft has taken well. There is some swollen cartilage which is still seen, but the subchondral bone has become healthy, and patient clinically has no symptoms at all. He is now 25 years and doing all activities, jumping, running without any pain and anything, because MRI takes a lot of time for subchondral bone to become normal. And if you see the upper right MRI, there is no fluid or signal changes. So that subchondral bone is healthy, because OCD type 1, you will see some fluid changes at the bone and the OCD junction, which is not there. So it has healed up very well, and patient is able to do everything. So this is what the indications of ACI and contraindication. You need to have a good subchondral bone. It needs a long rehab. And of course, it's a two-stage procedure and costly affair. So outcomes depends upon the size of the lesion. Return to sports is usually around 18 months in such patient. Age should be less. Clinical failures are seen at the end of 10 years, around 20%. And what MRI findings often do not match clinical improvement. Subchondral edema, cyst persist even in spite of high functional outcome. But this is the case, this is the procedure where it recreates a hyaline kind of tissue, which we all need so that we can have a good hyaline cartilage, but it's of course a costly affair. So ACI, other form which we all do commonly in our practice is mosaicplasty. This is a CRPF Jawan who had medial meniscus injury and this kind of condyle lesion. You can do ACI, of course, but then it's two-stage. You can do BMAC as well. But here, after discussing with the patient, and you can see the image down, there is a MRI clearly says that there is a grade 4 condyle lesion. I went ahead and did 6 plug mosaicplasty, definitely open mosaicplasty. And this is 18-month post-op MRI. You can see how beautifully the cartilage has regrown. You can see a mild, maybe 0.1 or 2 millimeters cartilage abnormality on the surface, but that doesn't matter. And the patient is selected for a medical category. And this is his improvement in the function. Even after mosaicplasty, there is no patellofemoral problems or graft site morbidity, though it has been highlighted in the literature, but a proper rehab and filling those defects again with the bad bone which you take out from the recipient side, it reduces your patellofemoral complication. This is a young ENT surgeon, again 35-year-old, sustained a fracture while playing cricket, and you can see there's a big 2 osteochondral fracture, but he reported to me after 6 weeks. So fixing those osteochondral fractures after 6 weeks, where you have very minimum amount of subchondral bone, will doesn't work. So I did all arthroscopic 4-plug mosaicplasty. The one thing whenever you are doing mosaicplasty, because the femoral condyle is convex, both anterior-posterior as well as from medial to lateral. So getting it perpendicular, though literature says you have to be perpendicular, but I feel it has to be little oblique harvest and little oblique because you have to be proud on one side and flushed with the other side. This, as the way it is shown in my lower video, the 4 plugs which I have used arthroscopically, it is proud in small area and flushed with the other area depending on the convexity, taking the knee through the full range of movement. It doesn't affect or locks the knee. And that's the post-op MRI at 18 months, which says that the whole osteochondral plug has healed up very well. And the congruity in the cartilage surface can clearly see there is hardly any subchondral edema. So given a choice, mosaicplasty is very helpful because you are transferring a hyaline cartilage one from non-weight-bearing part of the femur, deep femur, to the weight-bearing part of the femur. And it's a single-stage procedure, autograft, so no rejection, low risk of infection, and you get hyaline type of cartilage. If the patient comes to you early with this kind of osteochondral fractures, you can just clear the fracture and definitely you can fix them arthroscopically with biopin. If one fragment is very bad enough, you can remove and you can combine arthro fixation along with mosaicplasty, as in this case, as one fragment was very close and was carrying a lot amount of PCL fibers. So I thought to fix that fragment, lower fragment, which was attached with PCL, and with subchondral bone arthroscopically with biopin, and the above fragment, which was only pure cartilage, I excised it and used 2-plug mosaicplasty so that patient, I don't give him PCL instability, as well as I have filled the cartilage defect for more than 90% of the defect. So if you are doing mosaicplasty alone, see that you fill minimum 90% of the defect and leave very minimum space between the two pieces. And if you are using hybrid technique like this, partly fixing the fracture, osteochondral fracture, and partly you are using mosaicplasty plugs, see that you recreate the convexity of the medial femoral condyle, both in anterior posterior as well as mediolateral directions. Rarely you see such kind of door trap fractures where it is attached on the one side, and you can see there is a osteochondral defect. The thing here is clearly, completely clean the subchondral bone of the dead tissue, do multiple nano drilling kind so that you recreate the bone marrow coming and fix those door trap fracture also arthroscopically or open way. Nothing will happen in open way, but the thing that fixation should be very strong enough so that you can mobilize them very fast. As you can see, I have closed the door with about 4 to 5 biopins in different direction with about 4 mm in the depth, holding the fragment strongly. Another lady, chondral defect, very initial days of my practice, I used 3 plugs and did nano drilling or microfracture, what we usually do. MRI showed excellent healing, and reluxoscopy clearly shows that nano drilling of microfracture have inferior results later on. And here you can also see that my mosaic plastic plugs are so stiff and haline-like, but my nano drilling is producing some soft cartilage which gives good initial results for few years, but over the time, it deteriorates very fast. And you can see the donor side, even the plugs which I have taken from the anterolateral patella also heals with fibrocartilage. Rarely you see SPONG kind of lesion where the whole of the lateral femoral condyle in a 32-year-old electrician you see with pain and subchondral edema. So here the problem is again in the subchondral bone. Nothing, even if you put anything paste like ACI or BMAC, it won't work here unless you clear and make subchondral bone healthy. So here what I did open thing. I opened like a parapatellar approach. As you can see, the dead cartilage, yellow looking cartilage, cleared all that bad cartilage. And one thing, you should use your 11 number blade to have a perpendicular cartilage margin. Use the bone graft, did nano drilling, and used BMAC, bone marrow aspirate concentrate, and filled the defect here. And this was 5.6. After 5.5 years, the MRI shows that there is a good cartilage lesion healing. There is no or very minimum subchondral bone damage. Even in the fat separation image, you can see a complete white cartilage all around the lateral femoral condyle with hardly any bone marrow edema. Even in the coronal sections, you can see, and even in the axial cuts, complete healing of the cartilage. And that's the patient clinical picture after 5.5 years, an electrician enjoying his life and doing all activities of daily living without pain and without anything. So you can use single stage. Another one is now in the market is minced cartilage, where you take the free end of the cartilage with the help of a shaver blade, like you use the bone graft, where you take it from one iliac crest and you put it between the non-union site. This is the graft net. You take the cartilage or you shave the cartilage from non-weight bearing area and you paste it on the patella with the help of a glue. This is minced cartilage, also called as autocart, and you can fill those defects very well with single stage, may called as a simple cartilage grafting. And you can see on arthroscopy, it looks like a single stage procedure. Well taken, you can use BMAC in this patella lesions, you can use mosaic plasty. Important thing, return to sports. Definitely, nano drilling says return to sports may be more, but they deteriorate soon with the time. Hence, the gold standard right now, though cartilage, but availability and cost is a big issue. So what take home is, in my practice, if osteochondral allograft, that is oats, is my first choice because it's readily available on table. I can easily do it either arthroscopically or open way, and it is single stage, which you transfer the life. Nano drilling works well if it's a very small lesion and little older patient, less demand individual, but I prefer to do nano drilling plus I'll add BMAC to it, like bone marrow. You can use minced cartilage, as I told you, autocart. ACI is usually, I refer, getting lesser and lesser day by day because of good results with my BMAC also. And of course, if you have osteochondral fracture, fix it. If it's a chondral lesion or chondral fractures, try to fix it within 6 weeks. Thank you. Hello.
Yeah.
Thank you so much, Mukesh. Very nice
Yes.
lecture. And you have wonderfully shown the methods to fill up the cartilage gaps. Any questions to Mukesh?
I think one comment I'd like to make is for a general orthopedic surgeon, when a patient gives you a history of patellar dislocation,
Mhm.
and normally we treat it conservatively, put them in brace or maybe a plaster, but the pain and swelling continues for 1 week, 2 week, 3 weeks. Strongly suspect a osteochondral fracture. Now, very often these are not visible on AP lateral because the fragment falls in the gutter, usually in the lateral gutter, and you need a merchant view, not a skyline view. So AP lateral is common, but even the patellofemoral view done in most places, skyline view, which means they flex the knee completely. There you cannot see the gutters. So if you have a patellar dislocation suspicion, I think it is a must on day one. You should have a AP lateral and merchant view. You can sometimes miss this osteochondral fractures even on MRI. You may not miss it on a CT, but you don't get CT, MRI, everything in every patient. But very often patient comes with a AP lateral X-ray and MRI. And even in MRI it is missed because MRI is sections. Sometimes they don't get the right section and you can miss it unless you're very. But merchant view is one. If there is any cut, any bony sliver of bone with that osteochondral fragment, it can be found very easily in the gutter. If it is in the front of the knee, like in the notch as Mukesh showed, very simple, straightforward lateral view will show it. But very often they're not there and they can be missed there in the gutter and you can miss it for 2 weeks, 3 weeks. You're going around, MRI has been done, MRI doesn't report any fragment. And finally, unless you're very careful, you will not be able to find it and they'll end up with a chronic kind of synovitis kind of a picture. So this is a common thing I see missed and they come to us maybe to Mukesh after 4 weeks, 6 weeks because that osteochondral fragment has been missed. So I think that is the comment I would like to make.
So thank you both the speakers. That was a wonderful session, and really it is a really informative thing, both knee stiffness as well as cartilage lesions of the condyle. Any questions to? Yeah, Shalin, please go ahead.
Hi, sir. Good evening. Wonderful talks, Jeetu sir and Mukesh ji. Really enjoyed listening to both of them. Sir, I had one question to each. First, I'll go with Jeetendra sir. Sir, have you seen any issues with patients who have distal femoral plates put in slightly more distal? What that leads to is those locking screws typically going through the intercondylar notch, also impinging onto the ACL, PCL. Do those give any sort of issues of stiffness or challenges to the patient, those longer screws which go through the intercondylar notches?
So if your distal screw passes through intercondylar notch, I can understand that may damage the ACL or PCL or a part of it, but it will not give rise to stiffness. For stiffness, it has to be prominent on the gliding surfaces, either on the lateral side where the plate is there, or on the medial side if it is too long. But vitiating intercondylar notch doesn't have any relevance with stiffness as it is. It may damage the ACL. I don't think even ACL damage or PCL damage is going to be significant because it will be kind of a limited damage. So what happens? The ligament injuries cause problem, and when it is avulsion, when ligament goes like this, if you have drilled something into a ligament and a part of it is damaged, it's like a partial ligament injury. I don't think it will cause much problem. I don't think so. What do you say, Mukesh?
May I add to it?
Yeah.
Yes.
Shalinji, it's not about ACL or PCL which is causing a damage, because if you are fixing the plate so distal, it's almost near the capsule. So the capsule will be tight, and secondly, the lateral ligaments will be very tight. So that will lead to stiffness rather than cruciates.
Wonderful. And Mukesh sir, the question to you was this particular gentleman you operated for, the medial condyle, you had a lesion, the army personnel.
Yeah.
What was the reason for the injury? Was it a
It was a chronic meniscal tear.
chronic meniscal tear? I also, maybe it was the video was going fast, but he had a bit of a varus in his tibia. Do you feel that his overall alignment could have been the reason for the
Excellent question. It was a monopolar lesion. Nothing was there on the tibia.
Okay.
And patient has history of trauma led to meniscal tear, which he neglected, being a CRPF man, high demand individual. And that's why not adding, because it was physiological varus on both the sides.
Got it. Got it. Do you ever supplement your reconstructions of the cartilage with any bony correction of the alignment? Do you have ever sort of combined both of them?
I do that if it's a bipolar lesion, say adult femur around 45-50 with a root tear and a varus.
Okay.
Yes, I do that, but that should be a grade 2 to grade 3 medial compartment OA and not isolated cartilage lesion either on femur or tibia.
Wonderful. Thank you, sir.
Dr. Chandak, you do a fair number of trauma of all kind.
Yes.
What has been your experience with stiff knee after surgery?
Yes, exactly as you pointed out. I think the biggest problem we face is malpositioned distal femur plate. They are very anteriorly placed. I don't know. People are not able to dissect to more posterior level, and it remains proud, and then that causes more stiffness. And also the mobilization is quite delayed. They are kept on either slabs or the braces, which leads to quadriceps adhesions and then stiffness. And femoral lesion, as you said, becomes stiff more commoner than tibial lesion. So what you said, I totally agree. But wonderful points you brought out. Yeah. So thank you very much. We have exceeded our time. We're supposed to end at 5 p.m. Thank you so much. Let us
Thanks a lot.
continue this series in future also. Thanks a lot.
Dr. Chandak.
Thank you for sparing time, and thank you Ortho TV for allotting us this space on Ortho TV. Thank you very much, Rishi. Now you can stop streaming and we'll be closing down the meeting. Thank you.
Thank you very much. Thank you, Lord.
Thank you so much. Thank you, Rishi. Thank you so much.